Okay, hello everybody. My name is Arnulf Stenzl. I'm today trying to give you some perspectives of the patient's view from the first symptoms and actual diagnosis of bladder cancer to major surgery cystectomy. Now, these are that's the way how our webinar is set up. Most of you probably know already how it works. There's a presentation of about 30 minutes, and disclaimer. That's my disclaimer. Now let's jump into the topic. Like in every other oncologic surgery or oncologic intervention, compared to the non-cancer control, the diagnosis and the treatment of bladder cancer has a negative impact on the patients. Of course, the patient is then a little worse than he was before, or compared to other patients, no, not patients, other people that do not have cancer. So we really are giving them a problem. Now, when we look at the time to cystectomy, from the first symptoms to the actual intervention or the actual major surgery, there is a time period from the first symptom followed by the referral to the urologist, followed by the diagnostic, usually TURB, with a subsequent path report. That is a time period when we suspect something, and the patient as well maybe, but we don't know whether he needs cystectomy or not. From then on, when the path report comes, that is the time period when the patient actually is knows, or he's told by the doctors, urologists and others, that there is a major tumor, and the major tumor is most probably confined to the region of the bladder, and he needs cystectomy. And that is the time period when he is actually under stress of at one time knowing that he does have that tumor, on the other hand that the most probably curative surgery is awaiting him. So that is actually two periods, and we'll come back to that at the very end as well. Now, with regards to the first period of time, that is the first symptoms until the patient then is referred to the urologist, we also know that there is a difference, gender-related difference. Women need probably almost twice as long as until they are referred from the general physician, where the patient goes first due to his symptoms, usual symptoms such as pain or macrohematuria or recurrent urinary tract infection. And then the patient actually either gets treatment by the GP due to the assumption that it is maybe just a urinary tract infection, or just has some other reasons, and before he then is seen by the specialist. So it's twice as long for the women. And we also know from an Austrian multi-center study that the amount of women or the amount of treatment for urinary tract infection is twice as high in women than in men, up to 2 and more treatment for urinary tract infections in women before they're actually seen for further diagnosis in the direction of a possible tumor. And symptomatic treatment's the same. It's several times higher for women than for men for actually bladder cancer-related symptoms, which are just treated then under the assumption of non-oncological symptom or symptoms. And now, it takes longer for the women or the female patients to be referred to the urologist, but then the time they're waiting for a TURB, once they've seen by the urologist, actually is not that much, it's not actually longer for women, it's the other way around. So male patients are then a little longer, it takes a little longer to be admitted for a TURB for several reasons than women. And I'll come back to that in a minute as well. In Europe, we assume that we approximately have 1 million cystoscopies per year and approximately 300,000 TURBs per year. I don't know why, but that is not related to the population, but in Germany there seems to be the highest number of TURBs compared to the other bigger countries in Europe. And there may be certain reasons, but it also tells us maybe also that there are regional or national differences in the healthcare system that are responsible for some of the changes or some of the difference in numbers. Now, this is a Canadian study. And in that Canadian study, the time from the first actual symptom to the actual radical cystectomy in those patients undergoing this procedure, you can see that if you fragment that from the first visit at the GP, then referral to the urologist, time it's seen by the urologist for the first time to the cystoscopy, time to the TURBT, time from the TURBT to the staging, and from the staging then to the admission for the final radical cystectomy. That is the number in days, the average number in days, that the referral from the GP to the urologist as well as from the CT scanning to the radical cystectomy, those are the longest periods. That's where we lose. Each one of these two mentioned periods is approximately 1 month on average. So 1 month it takes from the actual CT scan and to prove the patient doesn't have any metastasis and that it's a regional disease to the actual admission to the cystectomy is quite a long period. Same as, from the GP visit to the first urological visit, 1 month, and that is something where one has to really think how and shouldn't we get better with this time. And that is outside urology, but within urology. Now, once he is seen, being seen by the urologist for the first time, delay number 2, and then he does have a cystoscopy then, and from the time of the date of the cystoscopy to the actual TURBT, that is actually the biggest difference which we see over time, because in that study in Canada, the time periods from the late 90s until the first decade of the 21st century has been compared, and you can see that is actually where we see the biggest increase of time, the biggest delay in time, and that should also give us something to think about. Do we have enough capacities in the hospital? Are we deferring for other reasons too long over the last few years? Because that definitely has changed over the decades. When we actually do then the TURBT, one of the things which is really important also is you have to get, as a urologist, when you do a TURB, you have to give a nice specimen to the pathologist, because if the specimen looks like these three here, then the patient, the pathologist is going to have a hard time really seeing the actual disease, the extent of the disease. Is the disease now invasive into the submucosa, or is it into the muscle, or how deep does it go into the muscle, and is there lymphangiosis carcinomatosa, for example? All these are important things, and the specimen should not be a charred, burned steak-like thing where it's very hard to read anything, but it should look like this, because then the pathologist can do a nice staging, give you a nice information, and the patient does not have to undergo a second or third TURB, most probably because we already have that incision. We have that information. And that is because TURB is not only a diagnostic intervention, it's also an oncological intervention. And we should have try really with all our effort and all our tips and tricks to really get a good information on what does the tumor look like, not only by the type of cell the tumor is formed of, but also by the extent of the disease, and there are several different tools to do that. It is a surrogate for the quality of a TURB if the Toussa muscle is present. So there are surrogate markers whether the TURB has been good, and that is also something which we can refer to the patient and give him assurance of the quality of that diagnostic but oncological intervention. And it's unfortunately also that training does play a role, because the surgeon experience is another surrogate marker for the quality of that diagnostic intervention. And with that in mind, we have to interpret the data again from Canada, that the number of cystoscopies in approximately 44% of the patients are not done at the first cystoscopy, and approximately 38% of the patients, the TURBT, or not the first TURBT, but the second, third, or even further TURBT actually does give us the actual information. So that is another burden for the patient. Of course, it sometimes has to do something that we want to preserve the patient. We want to have an excellent staging. But again, with the utmost quality of both cystoscopy and TURBT, we can sometimes spare the patient that additional diagnostic intervention before he before we have the actual diagnosis, and then can either decide whether it's not necessary to do a further major surgery, or if cystectomy is the which we tell the patient would be the best thing for him to do. We also have to think about, is there, for example, do bladder cancer patients are bladder cancer patients more depressive? Or are they depressive because of the disease? Or are they depressed because of the disease and the management, or our management of that disease, at least for time reasons and other reasons? The hospital anxiety and depression scale is one way of looking at the depression of patients, and you can see here, if that score goes above 8, we have approximately 10% of the patients in that study that do have a higher score as signs of anxiety and depression, and there is a small number, 3.6%, close to 4%, that do have clinically anxiety and depression. It's female patients, the type of tumor which you have, of course, the extent of tumor, and then the proposed surgical approach that is responsible for these. What is important to see is that the anxiety and depression score does not depend on the extent of the disease alone. So we also have patients that have, to a higher extent, the anxiety and depression also in the transurethral intervention, transurethral resection versus the muscle invasive bladder cancer and radical cystectomy intervention or surgery. What is important is to see that there are certain things that may be related to the timing, and maybe also related to certain groups of patients. And as you can see, especially when it comes to suicide, I mean, the suicide in patients, in bladder cancer patients, is related to diagnosis in the old days, so to say, 40, 50 years ago. Patients that are unmarried, white patients, older patients, male patients, patients with regional disease, and those patients not undergoing radical cystectomy. So those patients where they apparently get the impression it's too late for major surgery, you can't do anything anymore, more or less. And if you look at those that where the suicide rate is decreased after 3 years, those are the ones that already have been managed with that disease, and those where the actual suicide rate is decreasing is that after 3 years, patients seem to cope with the fact that they are not undergoing radical cystectomy. Those, although their older age, have been somehow been supported either by family or caregivers, and those patients unmarried, apparently their friends then jump in, or the family, or other, again, carekeepers. And those patients that have a regional disease, advanced disease, but still regional, they also seem to cope with that. And those are the groups that cope, whereas the other ones, white male patients, seem to be unchanged, and so they are still at risk for depression, and eventually, if not treated and handled the right way, may even lead to suicide. Now, one thing is, if you look here, the not only health-related quality of life, but that anxiety and depression, that is especially higher, considerably higher in those patients that are treated, but where cancer is still present. That is most of the time patients that do have a TURB. The TURB has not led to a complete removal of the tumor, and those are the patients that wait now for the maybe for the cystectomy, or maybe for a chemotherapy or other systemic therapy. So those, they know they still have cancer and it's not yet treated. Those are the ones that are having a higher, definitely higher anxiety and depression. So that is also a surrogate for showing us that we have in quite a number of patients a psychological problem. We have a problem that leads to anxiety and depression, and that type of anxiety and depression may be really dangerous. Coming back to that study in Canada, where with the fragmentation of the different time periods from the first symptom to the radical cystectomy, you can see that actually the time from the TURBT to the staging, and from the staging to the radical cystectomy, that staging, that is something which I, in my setting, cannot really understand. Why does it take so long when we have the path report, or when we have the TURBT? Maybe the path report is not coming early enough. Why does it take more than 2 weeks for the CT scan on average? Why is that? I mean, this is something where if you better integrate the actual hospital stay for the DRPT with the CT scan, then you should actually be able to reduce the time. Reduce the time when we also have clear a picture of whether there is metastasis or not. And if we do have that picture that there is no metastasis, then cystectomy should not take another month until it's scheduled. That is something where integration really should be done. Of course, we can have special imaging, but if we induce things like the VIRADs, the new staging system for invasive but more or less organ-confined disease, then we should also think about what burden do we put on the patients if we put that on all patients undergoing cystectomy to have a staging examination or imaging like that. That may prolong time because we don't have the resources for that. But on a regular CT, which is now in the guidelines, the recommended staging procedure, that should, with a better integration, not really to lead to such a delay. Of course, if you look throughout Europe, of course, we do have differences in various parts of Europe. And this is a Polish study, a very nice Polish study that has shown that the timing or the number of days until a referral to the hospital for the cystectomy was possible. Let's say the TURBT and the staging has shown it's a regional or localized, more or less localized disease. There are no metastases. And now they've divided that from the university level to the regional, to the provincial or regional. So getting smaller and smaller in the size of the capture area of each hospital. And it is really that those with the smallest capture, those are the hospitals that did have actually the lowest or the lower, the provincial and regional hospitals, they had the lower waiting time. So I cannot really, I would suspect from traveling around and from knowing a little bit the situation in Germany, that this is not the case really in my area, because we do have actually quite good resources, and that resources really more or less guarantee a shorter waiting period in the larger referral center, or the larger hospitals, the tertiary referral centers actually have a lower waiting period. But again, in the same group, it's a very nice study by Polish residents, actually, and they also have shown that, of course, the muscle-invasive disease versus the non-muscle invasive disease that have been, where their recommendation was for cystectomy, was definitely shorter for the muscle-invasive, for the more advanced disease. But the caseload, it also shows that if you look at the lower red square, the caseload, those with a lower caseload actually had 1/3 less, actually 2 months waiting period versus 3 months waiting period for those that had a higher caseload. Again, I think there are differences across Europe, but we do have large parts that do have showed this data, that the more cystectomies that are done in a hospital, then it may lead to a longer waiting period. We also know that the longer the waiting period, the delay until the patient actually is seen then, or where the patient is done, where the patient has been actually undergoing a cystectomy, if that is 4 months or 3 months in some studies, in that case, in that study it was 4 months. If it's more than 4 months, then the outcome is worse. Patients apparently have a shorter survival, cancer-specific survival, overall survival, than if we are acting faster. And if we're acting faster, if the patient from the first time when we diagnose actually a muscle invasive or let's say aggressive bladder cancer that cannot be treated anymore safely in a conservative way, if that is 3 months or 4 months or less, then the patients have a better chance of survival. And that we also have to keep in mind. Of course, it does not really come to the patient's mind, or he's not maybe aware of that studies in the majority of cases, but it really shows that apart from the psychological factor for the patient's fear, it is also something for the oncological outcome, which is better. Very nice study, actually an older study from Houtman, and it's just one example that patients that did have a longer delay in time, that these patients actually were not eligible for an orthotopic neobladder anymore. They were, to a higher extent, if it was more than a year from the first symptom to the actual disease, and these patients did not had a much lower percentage of orthotopic neobladder. Sorry, if it was less than a year, the chances of having a neobladder was higher. If it was more than a year, the delay from the very first symptoms to the actual disease in for example, initially non-really invasive disease was to a much higher extent than leading to an ileal conduit, and also leading to the fact that the initially organ-confined tumor, that delay to the initial organ-confined tumor actually did not only lead to a higher amount of conduits versus neobladder, but also to a lower overall survival. Again, here we have to be aware of the fact that the overall survival in female patients is lower than in male patients. And that is something which we again have to keep in mind, because that also tells us that these patients, that women are at the time of the diagnosis of bladder cancer usually have more aggressive disease, may be to the delay until they first see the urologist or until the first evaluation for bladder tumor is taking place in women, may also be to the fact that from an anatomical standpoint, an invasive disease will much faster be non-organ confined, and other reasons that may lead to that. So one of the factors is also we may delay the time to the cystectomy by a neoadjuvant chemotherapy. Now, from patients' perspective, of course, apart from the fact that with chemotherapy we have a 5 to 8%, according to the guidelines, better outcome if patients receive a neoadjuvant chemotherapy. These patients from that study also shows that according to the quality of life measurements, patients with neoadjuvant chemotherapy did have, these patients had a better emotional sexual function, they had a better mental health, there was a better urinary function, but the price for that, for the patients for having neoadjuvant chemotherapy, was a higher amount of fatigue, nausea, loss of appetite. So that is, from a patient perspective, that neoadjuvant chemotherapy. So we did a study in Tübingen, and if you look at the stress level, again, from the first symptoms, time to cystoscopy versus from the time from cystoscopy to TURB, from the TURB to the PATH report, that's the way we fragmented it, from the PATH report actually to the admission to cystectomy, because in our hands we can more or less integrate the CT staging into the hospital stay for TURB, and from the admission and cystectomy to the final pathology findings, because that is also something which may lead to, may have patients, has a different patient or has a patient perspective. You can see that the stress level is the highest in the TURB admission for cystectomy. That is actually the time when we actually know that it's an invasive, aggressive tumor and this patient needs a cystectomy. That's when they have the highest stress level. So, in conclusion, from a patient's perspective, the time to cystectomy is actually really dependent on, and what we can do about it is the training of the general physicians. And we as urologists and all those of you who are in training, then keep that in mind. We have to train the general physicians in order to help them better select the patients that should be referred to the urologist. The quality cystoscopy and TURB is important. Of course, the psycho-oncological support is important. But what is also important, what we have to keep in mind, we have to integrate the actual TURBT pathology staging and admission to the cystectomy. That is in our hands. That is in the hands of urology. There we have to find better ways to really do the actual shortening of the time, because that is where the patients have the highest stress level. So I thank you very much. I'm open for any questions for the topic here. Okay, now the first question by Reza Saria Montag. Why should we not do a cystoscopy and TURBT in the same time? 7 days can save. That is a very good, it goes into the integration. Now that I think we should not do that, because we have, for example, macrohematuria. We have a high amount of patients that do not have bladder tumors, and for that reason, we have a higher percentage that will have a cystoscopy without any tumor. So I think that it's a proposal. We probably could save those 17 days if we would do the cystoscopy and then the next day could schedule a TURBT. But I think that is the only way how you could reduce these 17 days, but not doing it at the same day. Now, next one, Tagan Arnulf. Thanks for the nice presentation. Thank you, Tagran. Why do you think bladder cancer patients' overall survival rate has not changed significantly in the last 30 years? That is a very, very good question. It is, I think you're right with the assumption. What you're saying is that the time from the actual symptoms to the actual treatment, be it radical cystectomy, bladder-sparing surgery, bladder-sparing strategy, or could it be any time delay? Yes, I do think that is part of it, but it's not the only one. We have improved only slightly with the systemic therapy. You know, cisplatin-based therapy has been there for 1988 was the first real the MVAC cisplatin-based combination therapy, and since then we didn't have any systemic therapy. We did not also try to integrate systemic therapy with cystectomy. And only in the last few years with the immunotherapy, with the data showing that we should integrate systemic therapy, be it before or after cystectomy, but we should definitely do that, that we really get a better handle on the actual oncological problem. I do think that we improved in somehow also over the last decade or more, but that on one hand, what we improved by getting a better treatment to the patient, we lost because, as you could see in that one Canadian study, because the time delay has become longer. So on the one hand, we do have better treatment, but we lose that the gain, the statistical gain which we see for the better treatment by more delaying, because the resources are not here, because our system is not working, and also maybe because we are not really aware of the fact how much we delay our time until we do an effective and actual treatment. Next one is from Truth's Truls Gardmark. Why do you not perform CT scan prior to cystoscopy? Again, this is the same thing as we said before. I am absolutely with you, Truls, that we should integrate it into the TURBT or the path report. Once we have the path report, integrate CTs there. So when the patient comes in, for example, for if necessary, if we can get it during his hospital stay for the TURBT, but if he has to come in a couple of days later for a discussion of his path report, that we then disintegrate the CT scan then. Yes, that would be a possibility. To integrate it into cystoscopy, too much of non-tumor related symptoms such as macrohematuria, and so we would do too much of a CT scan, and of course, we burden the patient and the and our healthcare system if we overdo it in that way. Okay, Goose van der Bosch, sorry. In what type of hospital is time between cystoscopy and treatment the shortest? For instance, smaller or larger, regional or university? A very, very good question. I don't think we have European data on that. We do have some Canadian data. We have the data from the Polish study, but the time between cystoscopy and treatment, for example, in Poland was in the smaller hospitals, in the regional hospitals, it was shorter for an admission for cystectomy. I don't know if cystoscopy to TURBT. You could assume that, for example, from our Polish colleagues, that may be the same, and that you could also suspect that would be the same in Canada, but unfortunately we do not have any pan-European data. I hope that we will have that possibility in the near future. Vilius Bossas, why not do a CT for all macrohematuria before TURB or cystoscopy? Again, I answered that question, but you're right, before TURBT. Now that is something, for example, if you have experienced people looking into and doing a cystoscopy and doing a bimanual exam, and that is something which we lose more and more, the clinical examination. If we do that more and more, then we can filter out those patients that may really need a CT or even do an MRI for a local staging, because we know that after TURBT, the local staging is totally different in after TURBT than prior to a TURBT, and then we can better differentiate between an organ and non-organ confined disease if we do it prior to the TURBT. Yeah, then your argument was we could save a lot of time and shoot a couple targets, example, hematuria for calculus hematuria and uterine carcinomas, or even if it's nothing seen in CT. Again, I would be with you. Yes, it is helpful, but you need clinical evidence that you should really do a CT, not too much, because it's, it's radiation, it's a burden for both the patient and the healthcare system. Now, the next one from Athanasios Georgalis, not sure if administration issues and also financial resources altered will make much of difference, considering that EU population not only is getting older, but also greater amounts. How do you feel about this? Well, I think that, you know, it's not only we can preserve some of the funding if we integrate. Again, I'm coming back to that. If we integrate the RBT path report discussion and CT into one, or at least path report discussion and CT staging into one timing, then we can also save money. And it does not mean that more patients, we should then spend less money and give them a less good treatment. I don't think, you're right, we are going to have that problem, but it is not really only financial resources that is our problem. We ourselves, in getting organized within urology, I think that is one of the things where we can issue things without having to need more money. Now, CT long time maybe is a question by Vilius Bosas. CT long time may also be related to a lack of radiologists, to maybe a lack of CT scanners. I don't see that in Germany, in some other countries, but you're right. Now, for me, a lack of radiologists is not an argument. There are two actual things in the future which may then happen. One is you have automated artificial intelligence-based reports of the CT. So why do we need a radiologist then? If we don't have it, before we don't get a CT, I'd love to have a automated report. And if we don't have enough radiologists, then maybe the urologist should buy a CT scanner. I'm not, hopefully radiologists are not listening to many that, yeah? But again, I don't think that is, if it's necessary, then there are ways, and there are ways to do that. And you know, again, we're talking about oncology, and then maybe and that is another thing, oncology cases, and that is bladder cancer as well, they need preference to the non-oncology ones. I'm sorry, they have to cut the line for an appointment for a CT, because here we're talking about tumor, and any delay of the tumor actual treatment will then need to be done by will need to be yeah. Now, Maximilian Goris, sorry, I can't read the third name. What is the real impact of the type of diversion on the psychological condition of patients after radical cystectomy? Oh, okay, Dr. Maximilien Gory from Marseille. Now, it was a time, the topic here is a time to the cystectomy. Now, again, for those patients not undergoing cystectomy, that is a problem for them, as I've shown you that. Now, the type of urinary diversion is a problem as well. We don't have very good data for that prior to the cystectomy. After cystectomy, yes, it does have an impact, but it does not have an impact in the first 1, 2, 3 years. Then the patients are really happy to have overcome the actual oncological disease. Only then, if they live longer, 3, 4, 5 years on, then all of a sudden the type of urinary diversion really affects them. And that is also, you know, when you have those undiversion surgeries. But also you see that then they are not really happy about the type of diversion sometimes. So yes, it does play a role, but prior to that, it may be the reason why patients do not undergo cystectomy. Mohammed Murad, do you prescribe neoadjuvant chemotherapy to all your patients? No, definitely not all our patients. Why not? Because as you know, in that age range, about 40 to 50% have an insufficient renal function. Any GFR below 60 actually is not a real good candidate for cisplatinum-based therapy, and that is the only one where we have to date really good data about having having a neoadjuvant chemotherapy. There are data from Milan, and there are data from pan-European studies, both with pembrolizumab and atezolizumab, which has shown that checkpoint inhibitors may also be of very good, may also be give patient an advantage prior to cystectomy. But again, we don't have those data yet, and those therefore you can only do it with those patients where they are fit for cisplatinum. Mostly it's renal function, but also hearing loss and others, which you see in that type of patients. Now, Hossein Roshani, you want to know whether open versus robot-assisted cystectomy does have an effect. Do patients, is it less of a psychological burden for open versus robot? If they're offered either open or robot-assisted cystectomy, unfortunately, I don't have any data for that. We've only done quality of life studies afterwards, but not before. Now, my assumption is, yes, there are patients in my own practice, and I only give you my own experience in that regard. Some patients, they definitely want their robot-assisted cystectomy because it's less invasive, whereas others do not really want that. You know, we have different kinds of personalities in that regard. But the only thing which we have to be careful is the resources with regard to robots and surgeons that can do safely a robot-assisted cystectomy is much smaller. So then we may have an even longer waiting time. So that is something where I would say the waiting time really may be not in favor of the radical robot-assisted cystectomy. Now, that is all the questions which we had so far. I think we have gone a little over time. I thank everybody. For discussion, everybody for listening, and I wish you a nice evening. Hope you can do something with the information which you just got now, and I wish you all the best. Thank you very much.